iliums and one sacrum and pubic symphysis here. Here you can see the difference of pelvic region between male and female. If we pass a triangle from this region in these two gender, you notice that the pelvis in the female are shorter and wider in comparison with the male. It is higher, and more skinny. Okay. These differences in the female, that the pelvis is wider, is due to the birth state of the newborn. It is easier for the newborn because there is two outlets in this region. Look at this. Here there is a outlet, that foramen. The diameter of this foramen in the male and the female is different together. As a normal indicator in your patients, it's very important that as a clinical assessment, you should check the alignment of the ilium. What is the meaning of alignment of the ilium? It means that the two crest of iliac should be in the symmetrical points. If you check this crest of iliac in both sides, both of them should be level. Symmetrical position of the ilium is very important. In some cases, maybe you found that one of the crest of the iliac is superior than other one. What is it happen? Usually, due to the habitual positions, some patients, for example, I habit that always during standing, I shift my weight toward the left side, always. It's my habit for many years. After sometimes you notice that the unlevelness of the keratoconus will be happening. Or in the sitting position. For example, this position of sitting, in this position, her weight is on the ischial tuberosity on the right side. Where is ischial tuberosity? This. When you are sitting, your weight applies, axial compression law, that yesterday I talked about it, applied on the ischial tuberosity. Now, if you have a habit that always sitting in this position, the always is under right ischial tuberosity. And so after some years, the imbalance of the left and right side of the ilium will be happening. And if it is continued and reach to the chronic conditions, it may be one of the source of low back pain and functional disabilities, okay? So you as a clinician, it is important to find any asymmetry of the ilium and other parts of the pelvis. For the check the asymmetry of the ilium, it's just enough that you stand behind the patient and put your hands on the crest of iliac like that, and then check the symmetrical position of your hands or not. For checking this, it's important that you put your hands in the anatomical position of the crest of iliac. Can you do it? Come here, please, to show your colleagues. Here on you. Come here. In your back pain. And so you should advise some therapeutic exercise to realign it to the original position. As we see here, there is a pubic symphysis in the anterior part of the joints. It is a symphysis, it is not a real joint, just symphysis. Okay? In contrast to synovial joint, it has not muscle, it has not cartilage, it has not cellular fluid. Just there is a disc. There is a disc between these two pubics and providing a symphysis here. Okay? There is a mechanical linkage between two iliums, sacrum, and hip joint. Look at it. Mechanical linkage between hip joint and sacroiliac disc. These movements, look at this. It's demonstrating the relation between them. In the posterior part, we have sacroiliac joint. In the anterior, we have hip joint. This mechanical linkage is regarding the movement. We have lumbopelvic ridge in our lumbopelvic region. What is the meaning of lumbopelvic ridge? It's very important. Listen to me carefully. When we are going to go to the flexion, it's a role that each vertebra moves separately, and in order of that, always superior vertebra moves on the inferior vertebra, stage by stage, okay, or segment by segment. What is the meaning of it? It means that first of all, during the flexion, L8 is rotated on the L2. Yesterday I talked about the flexion. I told you that during flexion, the superior vertebra comes to the anterior and inferior, and intervertebral disc, nucleus of the intervertebral disc, shifts toward backward. Do you remember? Yes. So now I'm going to tell you that during the lumbopelvic ridge in the flexion, first of all, L1 is rotated, and after finishing their movement of the L1, now is the time of L2. Now L2 is rotated toward flexion. After that, L3 is rotated. After finishing the rotation of the L3, it's time of L4 and then L5. Is clear? So during the flexion, all vertebrae in the lumbar region does not move simultaneously, but there is an ordering by movement of them. Segment by segment. Here, I ask the patient to go to the forward flexion. First of all, this vertebra, L1 rotate, it's stop, it's the time of L2, L2 stop, time of L3, then L4, and finally L5 will be rotated. After finishing the rotation of the L5, now is the time of rotation of the sacrum. Now is the time of rotation because the patients like to reach to the floor. I ask the patients go to the forward bending, okay? Now is the time of the sacrum. After finishing the rotation of the sacrum, it's time of the iliums. Both iliums go to the anterior pelvic tilt, okay? Go to the anterior pelvic tilt, and after finishing the rotation of the ilium, now is the time of the hip joint. Finally, the patient or individual go to the forward flexion in the hip joint. Lumbar, sacrum, ilium, and finally hip joints. So there is a linkage between the sacroiliac and hip joint. When you are going to the forward flexion, for example, stand here, go to the flexion, and sense. Do this movement with the concentration. Sense your movement. First of all, go the lumbar. Lumbar is finished here. Go, I check the lumbar. The L5 is rotate. Now, a little rotation. So, the little, go, sacrum, ilium, and after that is the hip joint. Do you sense that? experiences move? Yeah. Everybody can check it for yourself. That during the forward flexion, some of the movement occur in the lumbar, some of this occur in the sacrum, some of the movements occur in the ilium, and the final of this range of motion occur in the hip joint. It is a linkage between these three joints together. The name of this is lumbopelvic rhythm. It's a physiological. In some cases of low back pain or disabilities, especially in elderly, this rhythm is disrupted. What is the meaning of this? For example, I ask the elderly patient, go to the flexion, and he or she go to the hip flexion. Instead, flexion of the lumbar, sacrum, ilium, and then hip. Why? Because, for example, there is some DJD or pain in the level of the lumbar and sacrum, and he or she had a stiffness in this region, and so lumbopelvic rhythm is disrupted, and he or she prefer to have forward hip flexion instead lumbar and sacroiliac flexion. It is a pathology. It is a pathology. The main importance of understanding of the biomechanic is like that. If you know biomechanic, and if you found in these cases that the main problem of this case is lack of rotation of the lumbar region, and his pain is arising from this pathobiomechanics, so you as a practitioner try to realign the vertebrae and reproduce the normal kinematics of the lumbar region for him or she. Okay? In other way around, the other techniques that you apply for these patients is not acute cure of these patients, because the pathomechanics is existent. Okay? For example, some pain relief, some drugs, some exercise, none of them cannot work for this patient. Why? Because the pathomechanics is disruption of the lumbopelvic rhythm, and if I know the biomechanics, normal biomechanics, then I can have some solution for resolve it. In other way around, I ignore it, and the main problem and the source of problems of the patients remain. I understand? I understand? No? Who understand my words? Who understand that I said the explanation of the correlation between biomechanics and the clinical decision making? Who? I repeat. I told you that. Suppose that you have a patient that comes with low back pain. You know low back pain? Yes. The low back pain has variety reason. One of the reasons of low back pain, especially in elderly, in old person, is disruption of this lumbopelvic rhythm, that it is a normal biomechanic of this region. Is okay? Okay? So, if an elderly have a stiffness or pain in the lumbar and sacrum region, during forward bending, she prefer to fix these parts, and these movements should be omitted, and just flexion will be done in the level of the hip joints. Okay? Okay? It's a source of pathology. So when you ask, maybe you can notice in the some elderly that when they are going to bring a subject from the ground, they have this forward bending instead like that, because the lumbar region is damaged. Now, you as a clinician know this biomechanical issue. You know that in the normal cases, for normal kinematics, we need to have lumbopelvic rhythm. Is the ordering of L1, L2, L3, L4, L5, and finally hip joints. and then check the patients and notice that disordering is not appear in the case. So there is some techniques and some maneuvers that you can reproduce this movement for your patients. Okay? After the treatment, based on these movements appearance for the patients, the source of pathology should be dissolved and the real treatment will be applied for the patients. It's okay? Now understand? Why? Understand? Okay? Can you explain in Arabic?
يعني هو يعني يقول لهم مثلا يجي مريض عنده يعني باللمبر ريجن اكو يعني مثلا مرض معين يعني مو شرط تصادف انه يعني شكل يعني هو الم عنده فانت تطلب منه يسوي فلكشن وما راح يسوي فلكشن ما راح يسوي فلكشن من اللمبر ريجن بس راح يستخدم الهيب جوينت راح يسوي شيء يعني بينما هو يقدر يسوي شيء اللمبر ريجن لا هو راح يسوي بس الهيب جوينت يعني هذه له يعني علامة على أنه هذا يعني ما كنا خلل يعني هي دمرت يعني هي قاعدة تشرح أنه يعني حتى توضح لكم في المصطلحات.
Okay, I understand. Yes, it is the importance of biomechanics in your practice. It's one example. It's one example. In other way around, maybe some clinician that have no knowledge regarding to the biomechanics have another approach to treatment this type of cases. And it is not successful treatment because the source of pathology cannot be solved. It's likely to just use the pain reliever, really. So just another exercise that maybe is not working target to point for solving this problem. But when you assess the patient and find that, oh, I found that the local pelvic ridge is not happening normally as a biomechanical manner in these cases, and I try to have some solution in terms of exercise and maneuver to reproduce it for the patients, so it is obviously have significant improvement in their symptoms because you find the source of pathology, source of pathomechanics. Okay? It's that importance of biomechanics in the in your professional in the future. It is in all joints. Just one example. I have too many examples in all the joints, shoulder, elbow, wrist, knee, hip, lumbar, cervical, in all parts of the body. If you had this kind of approach to the patients, you have a superior to the others. You have superior to the others. I have too many Iraqi students in postgrad, MSc and PhD in Iran, from Iraq. And after too many years that we are working together, for example, when we are going to our school in MSc and now they are graduating from PhD, it's about 6 or 7 years. 6 or 7 years, 2 years for MSc, 5 years for PhD, that we are working together in the practice, in the research, in other disciplines, and then we come back to their country in Iraq. They notice, the others notice that they are obviously more intelligent and more professional. And last year, one of my PhD students nominated as the best physiotherapist in Iraq. Why? Because his power is based on his knowledge. His approach for treatment of the patient is scientifically based on the biomechanics, based on the pathomechanics. It's just not using the tools, devices, okay, or advising some similar exercise for the patient. You should notice that your prescriptions inshallah, in the future for the patients is like to the prescriptions of the drugs for the patients by the physician. And it should be different and should be per case for each patient, not as a usual, because it does not need to the anatomy, biomechanics, and other things. Okay? So, look at this picture. I introduce you sacroiliac joint in the posterior of the girder and pubic symphysis in the anterior part of the girder. Although we are talking about the joint, sacroiliac joint, but you should notice that the mobility of this joint is very, very small and too limited. Maximum mobility between the sacrum and ilium is about 1 centimeter. It's very little in comparison, for example, to the hip joint. But what is the main important biomechanical issue in the pelvic region? It is the stability. The main behavior of the pelvic region is stability instead mobility. This joint providing stability. What this stability is important for us because the pelvic girder is the transitional zone between the trunk and the lower extremity. So all the loads that apply from the head, upper extremity, and trunk and reach to the level of the L5 should transmit to the pelvic girder. In other way, the reaction force that yesterday we talked about from the ground should reach to the homolog forces from the upper part in the level of the pelvis. So the pelvis is the transitional zone for load transmission, and for this manner, this part should have high level of stability. Look at this picture. The weight of our body that's shown here with the arrow P, segment by segment, reach to the level of the L5. Yesterday we talked about the load transmission in the level of the vertebrae and intervertebral disc. Now, this level is reached to the L5 in the end of the lumbar region. The joint of the L5 has a joint with the sacrum. The first vertebra of the sacrum is nominated as S1. So we have L5, S1 joint here. In that level, the load of our weight divided into 2 symmetrical parts. One arising from the right sacroiliac joint, another arising from the left sacroiliac joint. So, for example, if the weight here is 40 kilograms, 2 kilograms run from the right side, 2 kilograms rise from the left side. In other way, the ground reaction force from our feet, from the ground, is moving toward the head of the femur. Here, you can see that reaction force demonstrated with R. This force is reached to the head of the femur, and these 2 equal force should be absorb each other in the level of the hip joint. This load come here, this load come here, and here these 2 symmetrical and equal loads should be compensate each other and disappear. And usually in our body, when 2 equal loads reach to other, providing a more stability. more stable. In both sides, it happened. At the same time, this reaction force divided to two different parts. One coming to the hip joints to compensate the weight, another moves in the ramus pubic. In the ramus pubic, and here in the pubic symphysis, another force should be reached to each other and compensate again this point or this node together. So here we have the compensation of the loads. Here we have another compensation of the loads. Okay? As a whole, in the normal standing position, when we are standing in our feet, right and left side, you can see that we have a ring. We have a ring of translation of the loads around the pelvis. All of these loads providing more stability in this region. And it is a good conditions for our body. Because first of all, the pelvis should be stable, and then we can move freely the lower extremity or the trunk. If there is any malalignment and changes of the loads in this ring, the equilibrium of this balance system should be disrupted. One of the important characteristics of the balance system is equilibrium. What is the meaning of equilibrium? It means the balance. Yeah. So if the forces in the right side are not equal to the forces of the left side, this balance should be disrupted, and our body should be shifted toward different directions, and it is providing some instability. For example, a patient that's suffering from the pain in the pelvis region during the walking like that. Why? Because the balance of this force is disrupted. In the normal condition, you are walking without any deviation or shifting to the right or left side. But if there is any disruption in this circle and in this equilibrium system that will be provided in the pelvic region, the imbalance and shifting of the trunk will be happening. Okay. How about the articulation of the sacrum and ilium? Actually, this is an amphiarterial joint. Can you see this line? It is the joint between sacrum and ilium. It is better to see. Sacrum and ilium. If we open this shape, you can see that there is a cartilage covered curve on the ilium and sacrum, like that. So here there is a semicircular portion on the sacrum, and like that we have a semicircular portion on the ilium that covered by the cartilage, but actually it is irregular, and these two should be connected together, and by this, sacrum and ilium moves around each other. Yeah, to ease the movement. So, it is a shape of the connection between the sacrum and ilium. It is an auricular portion of the sacrum, and actually there is too many deviation and variation in the position of sacrum in our body based on the type of the spine. How many types of the spine I introduced you based on the Delmas index? How many types of the spine? based on the Delmas index. Yesterday we talked about it. Normal. Based on the Delmas index, I divided 3 types of the spine. Normal, dynamic, and why it is compression? Why it is compression force? Who knows?
Perpendicular.
First one is that because it is perpendicular to the object, and second one is that because it is going to close this object together, so it is compression law. First one is that because this F2 is perpendicular to the surface, so it is the normal. And now I distinguish that it is compression or distraction, and I notice that this force like to close these 2 vertebrae together, so it is compression type. Another force, I told you that the weight of our body, because it's applied to the S1, is in the angulation, and it is not perpendicular, should be divided to 2 different forces. One is F2, that it is compression type. Another is F1. How about the type of F1? Based on the previous explanation.
Tension. Tension.
Why? Why? Just explain.
The force not going into the. It's out of the object. It's going out, so it will be.
What is the conditions that explain tension law? First is it should be
Perpendicular.
it is perpendicular.
Yes. No, it's not.
So
Yes.
this option is omitted
Yes.
because this F1 is not perpendicular to S1. Another choice.
Another choice. The force goes out.
What is the type of this force?
Tension.
Explain. Explain. In Arabic.
مش perpendicular فبنشيل التنشن عجلة مش تنشن.
Okay.
In a normal.
The normal cases should be put away because this force is not perpendicular. The another type of the force is
Shear.
shear. Is it shear force?
Yes.
Who says yes? You. And others. This is shear. What is the definition of shear force? Shear force is like that. In shear force, we have 2 parallel and opposite forces. So the F1, is parallel to this surface, and so it is shear force. You understand that the force of the weight of our body that applied on the level of S1 can be divided to 2 different forces. One compression, another shear. Okay? Compression and shear. It's happened in our body in all times, in standing position. This compression acting for increasing the stability between S1 and L5 because it is a compression. The action of the F2 is closest L5 to S1. It is a factor for our stability. If the F2 is bigger, the stability of the pelvis will be bigger. Okay? But regarding to F1 is shear force. I told you that usually shear force providing some damage in our body. So the shear force, the F1, that is the shear force, tend to sleep the L5 on S1. It is a tendency of a sleeping of L5 on S1. Look at this. It is the oblique conditions of L5, and here F1 is working and try to push L5 toward anterior and providing instability in our pelvis. It's a tendency. This tendency will compensate by the tension of the ligaments in the posterior part of the pelvis. So if you are going in the standing position, in all times, there is a opposite forces driven by the F1 as a shear force that like to slip the L5, and these ligaments in the posterior part of the pelvis that they prevent this slipping of L5 on S1 in the normal cases. I understand? So we consider that by increasing the tension of this ligament, the stability of the leg of the pelvis would be provided. Now suppose that there is some failure in these ligaments. What happened? If these ligaments cannot work in a proper manner and they have some fault and failure, what happened in the body? For example, some tearing of these ligaments or some loosening of these ligaments, that finally they cannot work ideally. What happened in this region? The force cannot compensate this shear force, and finally this slipping was happened. This slipping was happened because this force is not enough to tolerate this force. And by this slipping of L5 on S1, the low back pain should be appear. So the stability in the pelvis region is very important for the clients or subjects. Main part of the stability in the pelvis region is provided by the ligaments. There are, as you see, too many ligaments in this region that working for providing the stability of the different part of the joints. All of these ligaments should be worked carefully, providing stability. Do you have this book in your cell phone or laptops? Yes. Please go to the previous page that the name of these ligaments are mentioned on it. Let's review it together for better understanding. You can go to the page 70, open it in your cell phone or tablets. Are you ready? Because it is important to know carefully these ligaments, because these ligaments have the main role to providing stability of the pelvis, and sometimes we need to have some techniques to stabilize them for the patients. Are you ready? When you are ready, tell me. Ready? Book is ready? Book is ready? Starting from here, one by one, every student just nominate one ligament and then another one. Starting from ligament number 1.
The superior bundle. Superior bundle.
Superior bundle of which ligament?
Iliolumbar ligament.
Iliolumbar ligament. What is the origin and insertion of iliolumbar ligaments? Usually, it is the easiest way is that the name of the ligaments is based on their origin and insertion. Iliolumbar means that it is originated from ilium and inserted to the lumbar. But which vertebra in the ilium? Listen to learn better. Iliolumbar ligaments originated from which part? Superior band originated from which part? Some of you are silent. Yes. From S1 to ilium. What is the name of ligament? Number 3. Running is the it's not the name. It's running. It is the verb. Running from here to that one. The ligament running from the iliac crest. Can you see here? Yeah. Yes. The ligament running from the iliac crest to the transverse tubercle of S1. It's the sacroiliac ligaments, but you should notice that sacroiliac ligaments are too many ligaments that they are covered in different layers. Superficial layer, intermediate layer, and deep layer. It is in the intermediate layer of sacroiliac ligaments. This is the name of the ligaments, sacroiliac ligaments. So, number 3 was sacroiliac ligaments in the intermediate ligaments. How about the number 4? Posterior sacroiliac ligaments. Look at this. Posterior sacroiliac ligaments is arising from which point? What is about the origin? Yeah, in 4 different portions. You can see there are too many ligaments. 4. Yeah. There are 4 or 5 ligaments arising from the posterior aspect of the sacrum and connected to the ilium. They are as mentioned before. There is superficial, intermediate, and posterior layers of the ligaments. Okay, how about ligaments number 5? Do you download the book? You can find it on the book. 5. Sacroiliac. Anterior sacroiliac. You notice that there is too many ligaments that the name of all of them is sacroiliac, but in different layers. Okay. Yeah. Okay. How about number 6? Sacrospinous. It is very important ligament. Number 6. All of you told me. Ligaments number 1. Superior bundle of iliolumbar ligaments. Number 2.
Inferior bundle.
Yeah. Number 6. Sacrospinous. Sacrospinous. Number 7. Ischial and sacrum. Sacrospinous, sacrotuberous. Movement of the ilium toward inward. its anatomy. Inflate. When the ileum crest go out, the name is outflate. Inflate, outflate. It is a movement in the ileum that occurs in our body. Now I am talking that the nutation of the sacrum is accompanied by inflate of the ileum. So it means that these two movements are coupled together. Yes? Yes. Another movement of the sacrum is backward movement of the sacrum. It is a sacrum. Sacrum likes to go to forward bending. What is the name of it? Nutation. Sacrum likes to go toward backward. The name of this movement is counter nutation. Nutation, counter nutation. Okay? Yes. Again, there is a coupling between counter nutation and the movement of the ileum toward outward. Outflate. Here you can see. It is a counter nutation that is coupled with the outward notation, outward of the ileums, outflate. So it means that counter notation and ileum outflate are coupled together. Okay? It is an exam question. Nutation is coupled with which motion? Tell me. Nutation is coupled with which motion? No, nutation, I told you, nutation is coupled with which movement? No, nutation is coupled with the inflate of the ileum. Look at this picture. Nutation and ileum are coupled together. When the sacrum go to the nutation, the ileums come to the inflate. Okay? When the sacrum come to the counter nutation, the ileums go to the outflate. What is the problem? What is the question? These two movements are put together. Nutation with which movement? Inflate. Inflate. Counter nutation? Outflate. Show me the inflate by your hands. Inflate. Ileum. In the ileum. It's happening in the ileum. Outflate. Inflate. Outflate. Now, suppose that your head is sacrum, your hands are ileum. Go to the nutation with coupling of it. Nutation. Show me nutation in your head. Your head is sacrum, your hand is ileum. Show the coupling of nutation and counter nutation by yourself. I'm waiting. I sit here to see you.
Nutation, inflate.
Nutation plus inflate. Show me. Show me this movement by your hands.
Yes.
Nutation.
Rotation to inside. Yes.
Okay? I don't tell anything. I just see you. You.
هلا شوف.
I don't.
It's like the
وينك خويا راح تحول استنتروت.
Everybody do it. Is rotation and inflate. Rotation, show me. Rotation plus inflate. You should outflate, show me. It is the joint between ilium and sacrum. And non-sacrum likes to go to counter rotation.
Counter.
Allahu Akbar. Don't remember that. Counter rotation and outplay. Show me. What? She's vegan. Show me.
خويا هذا شيء بحال ما تقول.
What is that?
فعلا.
What is that? Which movement? Everybody has to do. You. No, you. Yeah. Counter rotation. Show me counter rotation in the pelvis. Counter rotation. It is coupled with which movement? Is it coupled with which movement?
Out.
Show me, please. Okay. From the pubic. I cannot hear. Pubic symphysis. It is a symphysis between two pubic rami. Look at this. It is the pubic rami from the right side, pubic rami from the left side, and reach together here. And there is a disc, intervertebral disc, between these two pubic. It is a symphysis, it is not a joint. And there is very thick ligaments for support this symphysis. What is the name of the ligament? Number 4, inferior pubic ligaments. Here is the superior pubic ligament, and in the anterior part there is anterior pubic ligament. So the stability of the pubis symphysis is provided by the ligament, just by the ligaments. And here you can see coccyx. It is the 5 fused bones in the coccyx that their connection to the sacrum is provided by these ligaments too. Sometimes in persons that have sleeping on the ground and have falling, this coccyx should be damaged or fractured. Or maybe there is some ruptures of this ligament, and the stability of the coccyx on the sacrum is decreased and so providing so many pain by this falling on the sacrum or coccyx. Okay, look at this picture. You remember that at the first part of this class, I told you that when we are going in standing position, our weight divided in 2 parts, right side and left side. Right side passes from the right femur, left side passes from the left femur. But it is up here during the static standing, but in many daily activity living, we are going to different positions. For example, during walking. What happens during walking? In each time, I take off my 1 foot, and so all of my weight should be transmitted on one side. And alternatively, we did it again in the other side. Yeah? Left side, right side. Left side, Right. In this situation, all the loads transmitted via one sacroiliac joint instead of two sides. And if the stability of the pelvis kept during these activities, everything is okay. In other way around, the stability is disrupted and maybe falling and imbalance should be happening. What happened during this? Look at this points. Here, show you the condition that the weight is transmitted from one side. In standing on the one leg. One leg standing is one of the clinical tests for assess the ability of the balance of the patients. One leg standing. The name of the test is one leg standing. Why it is important? Because the power muscles and ligaments should be working to keep the balance of the patients in this position. In other way around, the balance should be disrupted and it demonstrating that maybe there is a weakness or failure in the ligaments that I cannot stand in the one leg standing for many seconds. What happened? During one leg standing, the weight of the body transmitted to one side. And so the reaction force come to the one side and compensate these two forces together, okay? What happened on the other side? The other side, the lower extremity is take off. So the prediction is that we have a drop in the upper side pelvis. We think that maybe after removal the feet from the ground, we should have a drop in the other side of our pelvis. But it is not happened. Why it is not happened? Because the activation of the muscles in this region, they compensate the dropping of the pelvis. One of the muscles that help to stability of the pelvis in this condition is gluteus medius. The gluteus medius in the opposite side, contract and provide the stability of the pelvis in the correct orientation. So during the walking, you have not any disruption to one right side or left side. In other way around, if you have not a proper gluteus medius and a strong ligaments, during each step of walking, we have the limping. Lateral deviation will be happening. But by the powerful muscles, it's not happening. Stand up, everybody, and do this one leg standing test for yourself. Of the pelvis during one leg standing. It's from the lateral view. Again, it is the weight of the body, P, that applied here is the S1, is the joint. It is the tension of the sacrotuberous and sacrospinous ligaments that I told you they are two important ligaments. Look at this. The load P have a tendency to providing nutation of the sacrum, okay? The load of P, that is our weight, because this arrow have a tendency to bring sacrum toward the nutation. But it is not happened. Why it is not happened? Because sacrotuberous and sacrospinous ligaments tension don't permit to the sacrum that go to the nutation. They resist against the rotation of the sacrum. It is a normal condition, so everything is good and asymmetry is not seen. But if there is failure in the tension of the sacrotuberous and sacrospinous ligaments, they are loose, for example, and the rotation of the sacrum will be happening in bad conditions for the patient. So we need the proper activation of the muscles as well as proper length and tension of the ligaments to proper position of the sacrum. Look at to this picture. In this picture, you notice that the orientation of the ilium is depend of the posture of our body. For example, in lying sitting position, the rotation of the ilium is happen and hyperlordosis of the lumbar will be appear. Why? Because when we are going to extension of the hip, it is iliopsoas muscle. Do you know iliopsoas muscle? Iliopsoas. Iliopsoas originated from lumbar vertebra and come to the femur. Insertion is on the femur. In this position, this muscle has tension by the rotation of the ilium and hyperlordosis of the lumbar will be happen by the tension of this ligament. If I ask the patient, bring the knee in the flexion, the tension of the iliopsoas is decreased and lordosis of the lumbar will be resolved. So our recommendation for the low back pain patients during sleeping is in the crook lying position with the knee flexion instead of the lying sitting. Usually we recommend the patients to put a pillow behind their knees to have a rest and satisfaction and avoiding the hyperlordosis of the lumbar, because the sleeping providing hypertension of the iliopsoas and ligaments around the ilium. Okay, the pelvic region is finished. This pages is not necessary to read by you. And after this, in the next session, we are talking about the lumbar. Okay? Let's go to break and come back to the class at 10:30.